Hi, I'm Rachel Sirignano. I'm a pediatric critical care fellow. Today I'm going to be talking with you about heat stroke, how to beat the heat. I don't know if you know, but heat stroke has a 50% mortality. That means 1 in 2 kids will die from heat stroke. It's one of the unique illnesses in which injury occurs mostly within the first hour. That means you, as an early responder, could be an acting intensivist and potentially save a life from your early interventions. Our objectives today are as follows. First, I want to define heat stroke and try to explain a little bit behind this pathophysiology of a high mortality injury. Second, I want to discuss 4 mechanisms in which our body tries to use thermal regulation to decrease body temperature. Third, I want to utilize this pathophysiology and this thermal regulation to understand the early treatments of heat stroke. And finally, I want to list 3 measures in which you can help prevent heat stroke. What is heat stroke? Heat stroke is when our core body temperature rises greater than 40 degrees, and our patients then begin to have altered mental status. In our pediatric population, we will see this in 2 common scenarios. One would be an environmental induced, when a patient is locked inside a hot building or an enclosed car, or 2 would be exertional. For instance, when our patients are out training for football camp in the summer, they're using their power or fast twitch fiber muscles. Those muscles are working hard and creating lots of energy in which they can have thermal production of heat and an increase in core temperature. In both of these scenarios, our body starts to have breakdown from injury on a molecular level. When you're in this anoxic environment, the body core temperature rising greater than 40 degrees creates thermal energy to the mitochondria. Once you start having mitochondrial dysfunction, you start to begin to have oxidative decoupling. Through this, you will have a downward cascade in which our body responds through something called SIRS, or systemic inflammatory response. This inflammatory response is what creates the majority of the injury to our patients. After the molecular injury of thermal reaction causes mitochondrial decoupling, our body begins to start to release cytokines, creating this SIRS or inflammatory response. In the muscle, interleukin-1 and interleukin-6 are released and go into the bloodstream. Once in the bloodstream, our body recognizes the inflammatory markers and begins to react. At first, it wants to decrease bradycardia and decrease hypotension in order to upregulate cardiac output. But once your body becomes decompensated from this inflammatory response, you start seeing a coagulation response. Here, you will see increases of thrombin, fibrin monomers, and clots will begin to form. Once our labs start showing this increase of PT, PTT, and D-dimer, and this decrease in platelets, that is when you're going to start seeing altered mental status and strokes in our patients. This end organ damage becomes permanent, irreversible, and creates this 50% mortality. Our body is trying everything in its power to prevent this thermal injury from occurring. On an average day, you or me will use only about 5 to 10% of our cardiac output for our skin. But when we get to this point of high core temperatures, we can use up to 60% of our cardiac output, or 8 liters per minute, to try to create cutaneous vasodilatation in order to decrease our core body temperature and decrease that cascade of injury. But once you get to this point of 60% of your cardiac output to your skin, you start shunting away from your vital organs. ARDS starts occurring from lung injury. Acute kidney injury starts occurring. You are shunting away from other organs in order to try to prevent inflammation. And in doing so, we'll end up having decompensated cardiac function and complete shock. Before we hit this massive inflammatory response, our body has 4 ways in which it can thermoregulate its core temperature. In order to understand our thermoregulation, we need to understand the 4 key concepts of heat transfer, or the exchange of thermal energy between physical systems. Our teacher today is going to be the Governor of California, Arnold Schwarzenegger. I don't know if you've seen the movie Predator, but it is one of my favorites from the early 90s. In this movie, an alien predator is able to see his prey via radiation vision. And in order for Arnold Schwarzenegger to try to beat the predator and be invisible to his radiation vision, he covers his body in a layer of mud in order to insulate the radiation, decreases his body radiation, become blind to the predator, and be able to kill him in the forest. What does that have to do with our patients today? Other than the fact that I love the Predator and Arnold Schwarzenegger. When we're looking at our patients who are on the fields of a football field, for instance, they are going to lose their capability of radiation because of insulating their body. They're not going to cover their body in a layer of mud, but they may already have an innate layer of insulation through fat tissue, for instance, the lineman on the field. Or they may actually be wearing things, for instance, pads and helmets, which will insulate their body from the air and environment and decrease their ability to radiate. This is 60% of how our body helps thermoregulate our core temperature, and is 60% of the reason why our body could potentially overheat. Next, the most common one that people think of when they think of thermoregulation is via evaporation, or the change of sweat and water to a gaseous form. That energy transfer helps decrease our body's core temperature. When we're in a humid day, the air is already oversaturated with water molecules. And so when you're in a humid Atlanta summer day, it's going to feel very different and a lot hotter than a dry desert air, because our body has lost the ability to be able to evaporate sweat off the skin. The next way, or about 10% of how our body thermoregulates, is through convection, or the movement of wind. Flows of systems, hot and cold winds across our skin, and the movement of hot air molecules, and the transfer of heat from hot and cold air across our skin is 50% of how our body thermoregulates. It's why we feel different on a stagnant hot day versus a windy hot day. Lastly is through conduction. 5 to 10% of our body thermoregulates just via conduction of heat from our body to the things which touch our body. For instance, when you're out camping, a sleeping pad is going to help you be warmer at night because you're not going to conduct as much heat between you and the ground. So when the body's preliminary internal measures fail, how do we intervene to be able to help? Our treatment goals include decreasing the body's core temperature to decrease that inflammatory response and injury. We need to get the body's temperature less than 39 degrees Celsius within 30 minutes. The fastest and quickest ways to do this: 1, we can either use our evaporation and convection techniques to be able to cool off the body by using a wet sheet and a fan or a body cooling unit. 2, we can use conduction techniques through cold water irrigation. Or 3, we can just remove their pads, their helmets, other things in order to help with radiation of heat of the body. Now, when these patients come in, they are going to have altered mental status, and it's always important that ABCs are our priority: airways, breathing, and circulation. Our goal-directed therapy should be at end organ perfusion for these patients. But knowing that radiation is 60% of how these bodies thermoregulate, we want to prevent the body from stopping its own internal thermoregulation. So we want to avoid those alpha agents which will vasoconstrict the skin and decreases their ability to radiate heat. And we also want to avoid anticholinergics, which will then prevent their own internal ability to be able to evaporate off sweat and create anhydrosis in our patients. Our last-ditch efforts we can always do is extracorporeal or ECMO in order to regulate the temperature of the core bodies. But it is within the first 30 minutes that the majority of the injury will occur. So how can we prevent heat stroke from happening in our patients? 1 is identifying risk factors. We can use tools, for instance, like the wet bulb globe temperature, which looks at evaporation, radiation, and sun convection to know which days are going to be the highest risk for heat stroke, and we can tell patients how many minutes of exercise they can safely do in this kind of environment before they will be at risk for heat stroke. 2, we can do seasonal acclimation. Our body only takes 10 to 14 days before it can change and alter its internal capabilities to prevent heat stroke. We can also change their season playoff and practice in order to try to give them the full 10 to 14 days before putting them in a risky environment. For instance, the NFL will start with just no pads and no helmets when they start their summer training and work up to a full insulated workout. once the body has acclimated. And 3, we can use our thermoregulation techniques, which we have already discussed, in order to prevent heat stroke. In summary, heat stroke is when a temperature of the core body is greater than 40 degrees and a patient has altered mental status. Keys to injury are due to the inflammatory response to these high body temperatures. Thermoregulation, both internally and externally, through radiation, evaporation, convection, and conduction, can help in treating this, and prevention is key. Thank you very much for your time today, and I hope that this summer you too can beat the heat.